Thank you so much to Biotronik for making this happen. I'd also like to thank Siddharth and Oliver for having me here. So with that, I think while Siddharth was giving me giving his kind words of introduction to me, I was looking at this screen which read ICD troubleshooting. I think in the next few minutes, in the next 45 minutes, I'm going to give you examples, certain cases, walk you through as to what is it that we can do. ICD troubleshooting is a very big topic, but in the next few minutes, we will do it. However, while I was looking on this slide, you can see the various models that have been placed on this slide. And I often ask my fellows, and they often know the NASPE BPEG code for pacing. But whenever I ask them, what does VVE? Can you see this? Is my arrow visible, please? So whenever I see, supposing you look at this, look at this. Everybody, each one of us knows what is the meaning of VVIR. Each one of us knows the meaning of VDDR, DDDR. However, if I were to ask you, what is this word? Remember this terminology, VVE, VVDR. So the first three letters are unique to a defibrillator therapy, be it an ICD or be it a CRTD. You should be well aware what does this imply. Whenever we say VVE, the first letter means the chamber defibrillated. The next V is the chamber sensed and ATP is possible. The next letter E is how does it discriminate the rhythm, that is electrograms. So please remember this VVE is very distinctly different from the one that we use in pacing. With that, we begin into ICDs and typically an ICD troubleshooting. Even before I begin, I would like to give you a little historical perspective that ICDs were FDA approved in 1985. It took a very long time for them to be approved, but once they have been approved, there's no looking back. There are no more trials in ischemic cardiomyopathy to tell us whether an ICD is needed because it's proven itself as to how it helps in terminating arrhythmias and protecting our patients from sudden death. Typically, the defibrillator consists of the box, that is the generator, just like a pacemaker, and it consists of leads. The leads would be two leads, the atrial and the ventricular in cases of a dual chamber, and single lead if it is a single chamber ICD, that means it is a ventricular lead. Let me reiterate, there never is an atrial-based single-chamber ICD. There is always a ventricular-based single-chamber ICD, unlike we see in pacemakers. So also remember, they are not to be called AICD. They are called ICDs. While AICD implies automatic internal cardioverter defibrillator, it is a patent of a specific company and a maker. So always refer it to ICD. Undoubtedly, as I said, ICD treats ventricular arrhythmias. It does so by sensing, means it has to see every R wave inside the heart. After it senses it, it detects, it is taught that after you see X number of beats at a specific rate, you will detect that this is a tachyarrhythmia falling into a specific bin. After you have detected, you will give a therapy and you will terminate the tachyarrhythmia either by anti-tachycardia pacing or by giving cardioversion or by defibrillation to ensure the patient comes back into normal sinus rhythm. The most important part of an ICD and the challenging for an ICD, unlike a pacemaker, is sensing and auto-adjusting sensitivity. It is extremely important to understand that a defibrillator must reliably sense large and stable sinus R waves. Also, low amplitude ventricular fibrillation signals and auto-adjustive sensitivity is the solution that balances both the requirements without the programmer intervention. A very important point that all the young fellows must remember is for this very reason, when you implant an ICD, remember the R waves during an ICD implant must essentially be at least 5 millivolts. Also, when you implant the ICD, at that point in time, if you are finding that the T waves are very large, which can happen in some instances, for example, in hypertrophic cardiomyopathy, you may find very large T waves. In those situations, try and reposition the lead. It's important to understand that getting good sensing values is the first and foremost to an optimal operation of an ICD. So you can see in this EGM that has been shown how the auto adjusting sensitivity has to change from the tall R wave, the tall stable sinus R waves, to a small low amplitude VF signals, and at the same time it should not sense the T waves. As we go ahead, I will show you with examples, but remember, auto adjusting sensitivity is one of the first and foremost things of an ICD. This is a cartoon which you would have seen in any of the ICD lectures that you would have listened to. This is the ICD can. Remember, the ICD can is an active can, unlike a pacemaker, which is a passive can. This ICD can has the lead, and the lead is going into the superior vena cava, into the right atrium, and subsequently the right ventricle. You can clearly see in the leads there are two yellow thick lines, and those are ICD coils. This is the RV coil, and this is the SVC coil. Often today, we do not have the SVC coil, which we can discuss later as to why that happened. But remember, the lead encompasses the tip and the ring. The tip and ring are very closely spaced, and they are in contact with the myocardium. The point where the tip of the lead connects with the myocardium is called the virtual electrode. And at that point, what do you see? If you were to follow from above to below, look carefully. What do you see? This is the far field EGM. What is the meaning of a far field EGM? Far field EGM is the EGM which is picking up the vector between the ICD can and the SVC coil. If you don't have the SVC coil, it will pick up between the ICD can and the RV coil. So what happens? Remember, just like in ECG, an ECG is placed away from the heart, and it encompasses all the electrograms which are emanating from the myocardium, from the ventricular myocardium, and formulates the ECG. Similarly, the far field EGM is very akin to your surface ECG, as you can see here. And sometimes you can even see the P waves. So a far field EGM is for morphology analysis and allows you to identify what is the rhythm going on. Then comes our near field EGM. As you can see on this zoom picture, the near field EGM is the EGM which is picked up from the tip and ring, which are in very close proximity to the myocardium. What do you see here? This is the sharp EGM. It's a sliver of myocardium which is noted just under the tip of the ICD lead. Now remember, even this can have certain patterns, and as the myocardium has some dysfunction, the pattern can change from positive to negative. But remember, this is the near field EGM, which is a very sharp electrogram, and it should always be like this. It allows you to pick up the exact activity, what is happening in contact with that myocardium. And what do you see below is the marker channel. The marker channel is telling us what the ICD is seeing. Atrial sensing, ventricle sensing. So this is how it senses. Remember, if you have a single chamber VVI ICD, all it will see is a ventricular sensing. However, if you have the Biotronik, which Biotronik is the only industry which makes the VDD. In that case, it is a single lead. You will have the ability to see atrial sensing and ventricular sensing if the patient is given a VDD ICD lead. So that's about talking about the EGMs, which you should be very clear about. And of course, it's important to understand that the ICD lead, I already told you that either it can be a single coil or it can be a dual coil. The coil which always will be there is the RV coil. This photograph is trying to tell you what is the distinction between a true bipolar and an integrated bipolar. A true bipolar, as we've always learned, any bipolar lead picks up EGMs between the circuit is between tip and ring. So this is the tip and the ring. It's a very sharp circuit because they're very closely spaced electrodes, the tip and the ring. However, when we talk of an integrated bipolar, you cannot see the ring here. The coil is the ring. So remember, in an integrated bipolar, how will the EGM be picked up? The electrodes are between tip and the proximal coil. So it's a very large vector that it is going to see. In the initial stages, one of the companies had only integrated bipolar, but more and more of us depend upon a true bipolar. And if you have the ability to switch between a true bipolar to an integrated bipolar, it comes to help or handy help sometimes, which we'll again discuss at the later if we have any time left. You've understood sensing, how sensing happens, what are the EGMs, what are the electrodes, which makes us move to the detection zones and therapy programming. So remember, whenever you get an ICD, you have 3 zones which are available, a VT1, a VT2, and a VF. It is not imperative that you have to use all the 3 zones. You may use 2 of these zones, and you could keep the 3rd zone just for monitoring. So what happens? There could be some patients of yours who have slower VTs, non-sustained VTs, which happen at slower rates, and you don't want to offer them therapies, but you do want to pick up the VT. So you can program the VT1 as a monitor zone where it only monitors, does not deliver any therapy. You can go as low as 90 to 100 beats per minute. Whenever you program VT therapies, whenever you implant an ICD, it is the duty of the implanting physician to ensure that all the therapies are switched on after the ICD has been implanted. Whenever we have the VT therapies, remember, in VT therapies, you have first you could give anti-tachycardia pacing. After anti-tachycardia pacing, you start what is given, the cardioversions, and you can see in VT, we are giving cardioversions. Remember, in a ventricular fibrillation, in initial years, we did not have the ability to do anti-tachycardia pacing while the device was charging. Today, we have this unique ability of doing anti-tachycardia pacing because we have learned that sometimes even an ATP can help terminate very rapid VTs, which fall in the VF zone, but actually are monomorphic VTs. However, if it fails, what do you want to do? You want to offer in a VF zone, ideally, the maximum energy available. There is no time to lose. When a patient is having ventricular fibrillation, you should offer maximum joules that a device has the ability to charge and deliver. So that's how it works. Also, you can see in this very example, there is a VT1, and you can clearly see that the VT1 has been programmed for only monitoring the detection. So these are detection zones, as you can see. You can see above, it detects in VT1. Depending on which zone the cycle length falls, it will go either into a VT1 zone or it will go into a VF zone. Whenever it is a VT, it will look at the regular intervals, monomorphic, and of course, it is less susceptible to undersensing than ventricular fibrillation. So there are a number of intervals to detect. However, when it is ventricular fibrillation, the intervals are irregular, it is polymorphic, it has some susceptibility to undersensing because the R waves may be very small, which may not be picked up by an ICD. Hence, it is a probabilistic window that is given that 18 out of 24, 20 out of 24, which is programmable, and you don't want to miss a ventricular fibrillation. Hence, you program it such. Once it has detected the ventricular tachycardia or a ventricular fibrillation, depending upon which zone it falls into, it delivers the therapy that it has programmed for and hopes that it will terminate that arrhythmia. Should it not terminate, it goes into recharging and then it redelivers the tachycardia, it redetects and then terminates the arrhythmia. So that was about sensing and detection and subsequently therapy. Having understood that, we go into the ICD troubleshooting. Remember, the troubleshooting problems are identified at routine follow-up and, of course, troubleshooting in ICD shock. What happens on routine follow-up when a patient comes immediately post-implant and, of course, subsequent follow-up? When a patient comes on routine follow-up, make it a habit to look at the patient's site. You must look at the patient's site. Sometimes you could see there is a scab. Sometimes you could see that there is some redness. You could, in fact, see an impending exposure of the device. First is the inspection of the implant site, and subsequent to which you go and check all the parameters which are there. When you check into the parameters, the first and foremost, if the patient has had an implant in the past, is the battery status of an individual. So what do they tell us? They tell us you start from here. It's begin of service when the battery is more than 90%, middle of service 1, middle of service 2 when it is less than 40%. ERI has been now changed in certain manufacturers into relative replacement indicator. That is, it tells us that it will monitor the heart rhythm for at least 3 months and will deliver at least 6 maximum energy shocks and no change in the program parameters. But what is most important to understand, when the device is at end of service, now this is extremely important. Earlier it was called end of life. Now it is called end of service. In this, all VT, VF detection therapies are deactivated. So whenever a patient who has an ICD comes back to you and follow up, and when he has the ERI or an RRT indicator on, you must guide the patient to change the device and have a new device implanted, because you don't want an ICD to be picked up in end of service, because therapies can be unreliable. And when the patient is there, now you want to troubleshoot. So you want to see what's happening. You look at 3 parameters which are most important: sensing, lead impedance, and pacing thresholds. This is what you would do even for a pacemaker. But this has way more importance when you're doing it in an ICD follow-up. So a sensing, I told you, when an implant, the R wave must be adequate to reliably detect VF, and you want it to be more than 5 millivolts. And one word of caution: whenever you check any CIED, make sure that when it is being interrogated, you have the ECG also on your programmer. This is a very important thing. It will allow you to match the far field EGM with the ECG. It will allow you to see the threshold so much better. So always connect the ECG. Sensing, it's important to check for the sensing, the R wave. The lead impedance should be between 300 to 1000. Shock impedance 200 to 20 to 100. Please remember, if a pacing impedance changes by 30% in the lifetime of a lead, it's important to raise an alarm. If it has changed gradually, you may be very carefully watching the patient and calling back. But I will show you in an example. If there is a sudden change of a lead impedance, it means you need to change the lead. There is a big problem in the lead. Pacing threshold, voltage at twice the threshold provides safety margin. All of us with pacemakers believe the pacing threshold barely changes. But remember, in an ICD, you're dealing with a sick heart. You're dealing with an ischemic cardiomyopathy. He could have another MI. Having a myocardial infarction can sometimes increase the pacing threshold at the virtual electrode. So be vigilant and check all these parameters carefully. Sensing, you have already learned. I told you, hook up the ECG, look at the near field atrial EGM. The near field atrial EGM is tip to ring of the atrial lead. A near field ventricular EGM is tip to ring of the ventricular lead. Clearly, you can see very good sensing of both the P wave as well as the R wave. Hence, the importance of having the ECG hooked up. On the upper, you are seeing the marker channels. It is being sensed, and this is how you do the sensing check when the patient comes into your OPD. Lead impedance, I told you, if there is a change more than 30% in the lifetime of a lead, it is alarming. But look here what has happened. There has been a sudden increase in the impedance. Look at the bipolar threshold. It is 3.5. It is unacceptable. You want a bipolar threshold typically to be around 0.5, 0.75. You don't want to be 3.5. Look at the lead impedance. It's 1400 ohms. However, the unipolar threshold and impedance are fair. So let me show you why does this happen. ICD leads are complex. They're way more complex than pacemaker leads. Why are they complex? They're complex because they don't have just 2 conductor coils and 2 insulations, but they have a lot more happening, because there is a tip there is a ring, there is an RV coil, there's an SVC coil. So it's a very complex structure of the lead. They are multi-filar, as you can see here. There are so many lumens. They are well insulated. So remember, these leads can fail. They can fail because they're subjected to continuous trauma by the contraction of the heart. They can fail because of if your lead implantation, the lead is within the subclavian crush. There are many things that can happen to an ICD lead. So whenever you're checking an ICD lead, keep it in your mind. The ICD lead is complex. I should be careful with the lead impedance. The lead impedance, if high or low, raise an alarm. So you can see here, but you can ask me a question, how is it that the unipolar impedance is fine? It happens because the first thing to be injured is the external trauma. So the first coil or the insulation to be breached is the outer one. So the inner one remains all right, but you don't program unipolar in defibrillators. So remember, ICD leads are complex, and hence we've shown you these pictures that there's so much happening, multi-filar going in within the lumen. The threshold, you are well aware. I told you every time the patient comes for a follow-up, you need to check the threshold. The minimum energy required to stimulate the heart myocardium is what is the threshold. So here you can see 0.75 was successful. At 0.5, it failed to trigger. So the threshold is 0.75 volts. Thus, now troubleshooting the ICD shock. It cannot happen without knowing all of the parameters in the front, and then you reach here to understand what is happening. The most important element of an ICD troubleshooting lies in appropriate and inappropriate therapies. What is an appropriate therapy? The therapy delivered for a VT or a VF rhythm. Unnecessary therapy is detecting the ventricular arrhythmia, but treating it more aggressively with an ATP or a shock. What does it imply? It implies it could be a non-sustained VT, which could have terminated spontaneously. It could also mean that it could have been just treated with a short burst of ATP and shock may not have been needed. So these all come in appropriate therapies. Inappropriate therapy is therapy for anything other than VT or a VF. So this is extremely important to understand the two concepts of an appropriate and an inappropriate therapy, because what do we want to target is the inappropriate therapy. It is a well-known fact that a significant proportion of our patients get inappropriate therapies, unnecessary therapies, but more importantly, inappropriate therapies. And the commonest cause of inappropriate therapy is a supraventricular tachycardia. And of course, it can be T-wave oversensing, a lead fracture, and insulation breach. In clinical practice, one of the most commonest cause is an atrial fibrillation. Why does that happen? Remember, we're given an ICD to an individual with structural heart disease, ischemic, non-ischemic, LV dysfunction, large atria. They're prone to develop atrial tachycardias, which could be atrial fibrillation, atrial flutter, seldom even PSVTs. So supraventricular tachycardia is the commonest cause of inappropriate therapy, because this tachycardia can fall into the bin of a VT or into the bin of ventricular fibrillation. And remember, the device has been taught that when it sees a tachyarrhythmia in that bin, it must act. So a supraventricular tachycardia, like an atrial fibrillation happening at this rate, can fall in, wherein you may want to change there are certain algorithms that are available. In Biotronik, you need to switch on the smart algorithm, which allows you to identify if this tachyarrhythmia and distinguish whether it is a VT or an atrial fibrillation by certain elements, like, for example, the stability of a rate. If the rate is very irregular, it tells you it could be atrial fibrillation. Then it looks at the morphology criteria. Is the morphology more likely like a sinus? It will say, wait, or is the morphology unlike a sinus? And there is a percentage that can calculate to say that this is unlike a sinus, it is not matching the sinus, hence it is a ventricular tachycardia. It could also look at the onset. Is the tachycardia sudden or is the tachycardia gradual? If it is sudden, it's more likely to be a VT. If it is a sudden, it's more likely to be a sinus tachycardia. Supraventricular tachycardia, you just need to do certain programming. And as I told you, it is the most important element of any ICD to understand. And of course, then coming to noise. Most of us are confused when we see this, or we see this. the first confusion arises, what is each one of them? Which one is EMI and which one is a lead noise? So this is, fellows often get confused. Now remember, whenever you look at EMI, as the name implies, it's from external electromagnetic force. You can see here clearly, they are low amplitude and high frequency. Whenever you see anything happening, low amplitude, high frequency, both on the near field and the far field, think of an EMI. However, when you look at this is high amplitude and low frequency. So this distinguishing feature allows you to understand, am I dealing with an EMI or am I dealing with noise? So the noise, let me tell you, is high amplitude and low in frequency and will happen in the near field EGM. You're seeing that while the far field is looking clean, is telling you that this is more dangerous. EMI is not that dangerous for a patient because EMI you will be able to deal with, telling the patient, remove the external sources. There could be a washing machine in his house which is not well grounded. There could be any of this. There could be a geyser. There could be a swimming pool which he enters, which doesn't have good grounding. However, if it is a noise issue, it means the patient needs to be more watchful, and I will show you in certain examples. Lead fracture. Now look at this. This lead fracture, these things have happened. And if this is a lead fracture like this, how will you identify? The patient will come in an electrical storm receiving shocks. And when you interrogate the device, the impedance will be very high. Of course, you know, when you have a lead fracture, you will have to replace the lead. Then comes, you see the patient having a high impedance, as well as the patient you can see is having noise. What do you see when you look at this? Could be an acute implant and you see the set screw is loose. What does this mean? You look at the ventricular fixation point, you can see the lead has not emerged out of the set screw. So you know the set screw is loose. So remember, this typically will happen in an acute setting. And what will happen to the impedance? Impedance will be high because the circuit is not complete. So remember, these are certain features which you should be very well aware of to identify. An ICD lead with an insulation breach. How will you identify? The patient can come with an electrical storm, if lucky, without an electrical storm. But when you interrogate the device in your OPD chamber, you will see there is presence of lead noise. And what will happen to the impedance? It will be very low. Why will the impedance be low? Because look at this, there is an insulation breach. Because of this breach, the conductor coil allows the passage of current, easy passage of current into the tissues. Hence, the impedance drops. So these features are extremely important. And here you need to again replace the lead. So what do the EGMs tell you during troubleshooting? It tells you what was most likely happening and what is the most appropriate action you as a clinician need to take to manage the situation. For example, as simple as this, the impedance will be high, there will be an electrical storm. What do you need to do? Simple, you have to replace the lead. There is nothing else that you can do for this patient. Thus, how will these patients present? They will either come to you with a single shock, they can come with electrical storms, they can come with syncope. If the patient is dependent on ICD, even for pacing, they can again come with syncope, a resuscitated, SCA, or alerts from remote monitoring. So what do you tell your patient after you give an ICD and discharge him? You tell him that if you receive a single shock, don't panic. You can come for a routine follow-up, or you can come in a week's time. However, if you get an electrical storm, implying if you have 3 or more therapies in a single day, he must come to the emergency room because it could be an inappropriate therapy or it could be an appropriate therapy which needs immediate attention. So these two factors are extremely important when you discharge the patient and let them know the distinction between receiving a single therapy and receiving an electrical storm. They should know that an ICD has been given and there is likelihood that he will receive a therapy. So that's a message which should be very clear because sometimes patients get very alerted even by a single shock. So when the patient arrives, you do the analysis of ICD shocks. You look at the stored and clinical data. You've already known, is it a tachycardia or is it no tachycardia? If it's a tachycardia, we've already discussed, is this a supraventricular tachycardia? Most likely a flutter or a fibrillation, which would mean inappropriate detection, or is it a ventricular tachycardia, which is an appropriate detection? If you see there is no tachycardia, then you want to know, is it an intracardiac signal? As I told you, is it a lead issue? Or is it an extracardiac signal? As I told you, an electromagnetic interference. So once you've seen this, whether it is tachy or no tachy, the therapy will proceed accordingly. If it is a tachycardia of a VT, you want to terminate the arrhythmia. And if it is no tachycardia, it will either be a lead replacement or a device replacement or nothing at all if it is an EMI. Which brings me to some cases which I will show you. Here is a patient who feels dizzy, then receives a shock. Now, look into this EGM carefully. First, always see what EGMs am I seeing. You can see this is an atrial EGM. It's a near field atrial EGM. It's written here, RV sensing. It's a near field ventricular EGM. And what is this? This is the far field ventricular EGM. So the first thing is to see this. Then you look in here. The patient is dependent on the ICD for pacing also. Every far field is reading the patient is getting ventricular pace. But what happens here? You can see on RV sensing, the near field EGM, you can see that nothing is happening, but you can clearly see that there seems like something happening here, which is very small. You can see something happening here. And what do you look at the marker channels? The marker channels has detected it as ventricular fibrillation. So what do you think this should be? Do you think this should be myopotential oversensing, electromagnetic interference, T-wave oversensing, or a lead fracture? Now, if you were to take each one of them, it's not a question of you answering it correct. It's a question of understanding them all. Clearly, I told you that if it is a T-wave oversensing, let's start with T-wave oversensing. For that, you look back. Is there any T-wave sensing here? No. Second, it should not have had an asystolic spell. There is a ventricular fibrillation which has been detected while nothing is happening in the RV electrogram. So it's not a T-wave oversensing. Can it be a lead fracture? I told you in a lead fracture, there should be high amplitude, low frequency EGMs not happening again. So it's not a lead fracture. Can it be an electromagnetic interference? Yes, you can think about that. Can it be an electromagnetic interference? Because I can see that there is low amplitude, high frequency EGMs on the near field EGM. However, remember for an EMI, typically you should have it on other markers also. You should have it on the atrial also. You should have it on the shocking coil also, ideally. So it's unlikely to have electromagnetic interference. So the answer here is myopotential oversensing. Remember, when there is bradycardia, myopotential oversensing is amplified. What happens in this? The near field EGMs pick the near field EGM, the tip to ring from the RV lead picks up the myopotential, diaphragmatic potentials, and thinks that the ventricle is contracting and inadvertently tells that it is ventricular fibrillation, and these patients can even receive therapy, which brings us to the point of having auto-adjusting sensitivity, which it adjusts over the course of the cardiac cycle. I told you it allows to sense the tall R waves at the same time must pick up ventricular fibrillation signals, avoiding the T waves. It allows for the sensing of fine VF waves while avoiding the sensing of T waves, and programmed sensitivity represents the minimum sensing threshold, means it is nominally set at 0.3 millivolts. So this is what is happening here. You can clearly see that this is the R wave, the tall one is the R wave. Subsequent to that, there is a T wave. And here you can see in a pacemaker, there would be a fixed sensing threshold. It would only see anything more than 2.8 millivolts. But unlike that, in an ICD, the sensing is anything above 0.3, it will see. So you can see here the patient's R wave, which was more than 5, was sensed. And subsequently, it sensed these myopotential diaphragmatic signals as a ventricular fibrillation and sensed them, and hence withheld pacing as well as gave a therapy. The next case is this. This patient attended an OPD because there was a device alarm. So what do you see here in this case? You can clearly see here, this is the near field EGM, this is a far field EGM, and this is the marker channel. So if you look at the near field EGM, you can clearly see there's something happening here. In the far field EGM, and now I've told you what this is, low amplitude, high frequency. This is an electrogram which is showing low amplitude, high frequency, which has been picked up by an ICD as ventricular fibrillation. You can see it's ventricle sense and then fibrillation sense. But look at the cycle length. It is 130 milliseconds, 130, 280. So this is, it has detected it as ventricular fibrillation. So what do we do now? So this is the, you can see the EGMs here. This is how it was going. And suddenly it came into the rate, the cycles came into 180 to 200 milliseconds, the high rate intervals of 120 milliseconds, and a very irregular pattern which did not appear a true VT or VF. On looking at the main screen, what do you see? There are several monitored episodes, no treated episodes, and the device was taught that if it were to see something like this, there should be an integrity alert. So this integrity alert came up. And however, if you see a lead integrity alert, the most important thing to look is for lead impedance. So you can see here, the lead impedance has been stable. The impedance trend has not changed. So what does that tell you? If there is no lead impedance trend change, you know there is no problem with the lead. However, it detected it as VF because it thought it detected it as VF because the cycle length fell in the VF zone. But what was happening here? It was nothing but an electromagnetic interference where this happened when the patient went into the swimming pool because the swimming pool electrical grounding was not good enough. So remember, this is an EMI which you should not forget. Bringing you to the next case. The next case is a patient who's had multiple shocks. He comes to the ER. So what do you see here? Near field EGM. Clearly you can see a near field EGM is showing you something, the EGM here, there's something happening here, something here. You can't see clearly what is happening. Is it a real VT? What's happening? You don't know. But if you were to focus to far field EGM, it cannot happen that the patient is having a VT in the near field and there is no VT in the far field. It doesn't happen like that. So if you look at the far field EGM, CAN2H-B, what do you see here? It is stable rhythm. It is absolutely stable rhythm. There is no VT happening. Now focus your eyes on the marker channels. The marker channels tell you that there is a fibrillation happening. Now how can this happen? It is detecting it as fibrillation while the far field says it is stable rhythm. So there is a problem here. What is the problem here? Again, this is, look at the scatter. The scatter is everywhere. The sensing has gone for a 6. It's sensing all abnormal parameters. Why is it doing so? It is doing so because of this. I told you, if the lead impedance suddenly changes, you get to know that there is an insulation breach or a conductor coil fracture. So here the impedance has suddenly increased. When the impedance suddenly increases, it means there is a conductor coil fracture. This patient has had an electrical storm. You can do nothing for this patient, but this patient will need a change in the ICD lead. The next case is a CRTD implanted 8 years ago. The patient received a shock 5 days ago. So that means he had a recent shock. The patient was not symptomatic prior to this shock. Now, this history is extremely important. When the patient says, I got a shock, but I was absolutely fine, it tells you 2 things. 1, was it really needed? Was it inappropriate? And second, if it was appropriate, even for those patients, you could probably consider adding an anti-tachycardia pacing or waiting longer because the patient does not have a near syncope or a syncope. So always remember, a history prior to shock is very important. So coming back to the case, it's an old device, but he received a shock recently. He had 6 VF episodes, 5 non-sustained, and 1 receiving therapy, the one that he came with. So what is it that had happened? Look here now. Our tip to ring. I told you this is the near field EGM. What are you seeing on the near field EGM? You're seeing high amplitude, low frequency signals. What's happening on marker channels? Clearly it is saying fibrillation sense, fibrillation detected. But thankfully here it did not give therapy, because after that the cycle length changed and it fell out of the VF bin. So you can clearly see there is something happening with the lead, because large amplitude, low frequency. And if you look carefully, you can also see there is an insulation breach. And whenever you see an insulation breach and you see this plot of the intervals, you should know there is a problem with the lead. And the answer to this problem again is the patient must undergo lead replacement. There is nothing else that will work here. There is no programming that you could do, because the patient needs stable rhythm monitoring. Sensing, we told you, has to be very good. So this is another case. Patient came for a follow-up. What do you see here? So whenever somebody gives you this EGM, you have to look and identify what is happening on this EGM. The upper line is telling you it's a near field EGM, tip to ring. The lower is far field EGM, which can be between the CAN to SVC coil, the CAN to RV coil. It can also be, the far field can also be between the SVC and the RV coil. Typically, we don't have that, but you should be knowing. So this, and the third one is the marker channel. So you can see the near field EGM. Clearly, you can see it appears like something is happening for sure. You may even think it's a VT and it's been picked up by the device. But when you look your eyes to the near field, to the far field EGM, which is like an ECG, you see there is no VT happening. That means the lead has an issue and the ICD is picking up abnormal signals because the lead has an issue. By now, you would have understood this. What is happening here is the patient's lead has an issue, and this is called high amplitude. High amplitude, you can see the signals are high amplitude with low frequency being picked up as fibrillation. Hence, the answer to this patient will be that you must change the lead. Look here. The last one again, you can clearly see there is a breach here. Now, the impedance will tell you, is this a conductor coil fracture or is this an insulation breach? But the answer will be the patient will need a new lead. Again, patient admitted in ER with electrical storm. I told you, low amplitude, high frequency. Low amplitude, high frequency. What is this? This is, also look on the other channels. You can see on the near field channel also you can see that. So whenever you see on both the channels and it being picked up as FS, you know this is an EMI, this is an electromagnetic interference. Unfortunately, if you look here, this patient's, it was inappropriately diagnosed as fibrillation, fibrillation detected, and charge also delivered. You can see here 34 joules has been delivered to this patient. So remember, whenever these patients come, you have to be good at looking at sensing, look at the impedance, and look at them so you know what to do. Here is another example, which you can see there is oversensing taking place in the right ventricular near field EGM. You can see there is, now you can make out, I'm sure, that this is a lead noise and it has been detected as ventricle sense. And when you look at this, the patient's impedance will be high or low and the patient will need a change. This will be my last case. You can see here the patient is having paced rhythm. There is A sense, V paced. You can clearly see suddenly something happens where there is just P waves and there is asystole. So for a short period of time, there is P waves, the patient is patient dependent. So something happened. The device sensed that there is something happening in the ventricle that's called ventricular oversensing, which could have happened for many reasons. And we're trying to identify why did this happen. Look here. So this is what happened. So on the near field EGM of the ventricular lead, what do you see? You see it has detected it as a VT. It thought that there is an atrial activity happening. It did not give any ventricular pacing spike because it thought there was VT happening, and it delivered a therapy. In fact, it gave a charge of 25 joules to the patient. But what was really happening, which you should know, there is something called these, they are not so common, but you should be aware. Sometimes they can be air in the header and they can give rise to such signals, and you should be cautious about them. So you should be clear that oversensing can happen for various reasons. Most often it's a lead issue, but yes, sometimes you can have some abnormal, uncommon things happening, which you should be ready for. I think in the next 10 minutes, we'll be happy to take questions. Thank you very much.
Thank you so much, ma'am. This was absolutely outstanding session. Thank you very much for your time. Ma'am, we have a question in the question and answer session. So I would like to raise that question. One of the participant has asked, what is the current status of DFT testing and is it still being routinely performed? Ma'am, could you please share your perspective on this?
Yeah, that's very nice. So when I started implanting leads, we used to do defibrillation threshold testing. However, over the years, we've stopped doing DFT. The reason being, whenever we do DFT, remember it's a probabilistic. It does not mean that when you do a DFT, it will sure shot terminate arrhythmia in a clinical setting. Is that the reason enough? No. The second reason is we have devices which are very robust. Earlier we had 30 joules. Today we have 40 joule devices. They are extremely successful. We have learned that they work. Third, whenever we do DFT, unfortunately, there have been times that our patients have fallen sick. However, there are certain situations that you may want to do DFT. For example, if a patient comes back not having received a therapy which was unsuccessful, because you may want to add some array, you may want to change the device. So there are certain situations where you want to do DFT, but as a routine, we do not do DFT testing anymore.
Thank you for addressing the question. And I'm sure this must be very hectic for you, but we have two more questions if you would like to address them as well.
Sure.
So the second question is, people would like to know a word from you about subcutaneous ICD and wearable ICD.
Very nice. So let's start with wearable ICDs. So wearable ICDs came in and they were in India too. The problem with wearable ICD that we had was that there's certain issues of oversensing. Having said that, still there is a certain subset of patients which really need it, but for many reasons, one of them being economical, because it had very high rental values. We could not sustain it. It was very few patients needed it. So the wearable ICDs, we don't have them in India. They've gone. However, subcutaneous ICD is an emerging market. We look at it with great optimism. The reason being that today we are living in a time where we pick up inherited channelopathies. We want to give devices which would help individuals with channelopathies like Brugada, ARVD, long QT, where they come with ventricular fibrillation. They're young patients. They are advocates for just defibrillation, and the vascular system is preserved. So yes, we are looking out at subcutaneous ICDs aggressively, but you should remember subcutaneous ICDs have their own challenges even today. For instance, they are unable to provide anti-tachycardia pacing, which we have learned is a very good uh, painless therapy for our patients with VT, and sometimes even with very fast VT, which falls in the VF zone. So each of these therapies are unique. They're helpful for our patients, for a given subset of our patients. I'm a perennial optimistic person. I believe that the utilization of subcutaneous ICDs will certainly increase with as technology evolves itself.
Thank you, ma'am, for taking up this question. We are actually having two questions on the same topic. That is from the last part of your presentation. We have been asked that the air in the header, the part that you have shown in the last part of your presentation, can you explain it a bit more if that is fine for you?
Yeah. So what happens is basically it's very uncommon. So sometimes what happens is that when you put the lead in and your lead has not gone as distal, or you've not screwed it well enough and you think you've done it, there could be certain amount of air which is left. These are very uncommon things to happen. The reason that I showed that example is if you see a noise, you should not always go back that I have to replace the lead. Go back and while you're doing an implant, make sure that the lead tip goes beyond the header, the screw. Make sure that you screw it well. Make sure that you pull it back and see that it is very well fixed. Make sure that you get good sensing once through the programmer and you're checking it before you close the pocket. So air in the header is very unlikely, very unusual in times of today. But if you don't do your procedure well enough, you could sometimes be in trouble.
Thank you for the explanation, ma'am. I hope it is clear now for everybody. Ma'am, we are coming up with a lot of questions. So the next question is how to manage the VT storm in ICD.
Yeah. So I think that's wonderful. How do I manage a VT storm? So first thing for a VT storm, take the patient in the ICU, put the patient on defibrillating patches in the ICU setting, and you should ideally switch off the device. You should be ready to defibrillate or cardiovert externally. You don't want to utilize the battery of the device in an ICU setting. Most important, sedate the patient. Completely knock him off. You may even want to intubate the patient and keep him deeply sedated. Look at the hemodynamics of the patient. If the patient comes with monomorphic VT, the first drug of choice after having corrected serum electrolytes, potassium at 4 to 4.5, magnesium at 2, the drug of choice for a monomorphic VT is giving IV amiodarone via a neckline, 300 milligram IV 8 hourly. Alongside, whenever there is a VT storm, remember you should want to give non-selective beta blocker like propranolol. If the patient's hemodynamics allow you, you may even consider giving intravenous esmolol. Now change it, flip it. If the patient comes with polymorphic VT, the drug of choice is IV Xylocard, lidocaine. Do not give IV amiodarone. It is not the choice of drug. Sedate the patient, give IV lidocaine, give beta blockers. Supposing you've done this and the patient continues to have a VT storm, you should want to go and do sympathectomy. So go and give ganglion sympathectomy. You could do it bedside. So after that, in case it doesn't still work well, you want to up titrate the drugs. The drugs left with you will be beta blockers. Also remember that you have to identify, hopefully you're not dealing with a VT storm of Brugada, because the treatment choice of VT storm of Brugada is very distinct, where it's isoprenoline and quinidine. I'm not touching there. I'm touching more common ones like ischemic VT. So in ischemic VT, sedate, first switch off the device, correct the electrolytes, sedate the patient. Most important, cut off his sympathetic drive by sedating. Make sure you give IV amio, IV lidocaine, depending upon morphology of the tachycardia. Make sure you give IV esmolol, give IV propranolol. If you see the patient is developing any evidence of QT prolongation, add mexiletine. Sympathectomy, if the patient needs ganglion sympathectomy, which can be done bedside, sympathetic blockade, ultrasound guided. VT storm is something which needs to be treated on very carefully, but doing these things, you are largely able to bring them out of the problem. Since we have a minute left, there's a question which I want to tell that if it's a VT storm, you lead fracture and patient is not near a programmer. So I think we must answer this because they must go back understood. So you can keep a magnet or of 10 gauss. You should be sure that it is a VT storm because of lead fracture. Remember, the patient should be accessible to external defibrillation if he were to have a real defibrillation, the real VF. But yes, you can keep a magnet on the device, 10 gauss, and it'll stop the therapies. So this is, you should remember. I think I have 30 seconds more difference between single coil and dual coil. We don't use dual coil now anymore because we have realized that the defibrillation thresholds are identical, nearly identical with single or dual, and extraction of dual coil is more difficult because it gets embedded in the superior vena cava. How to treat slow VT at a rate of 150? Well, it's largely the same. If the patient is having recurrent, you may want to go take him in and do a radio frequency ablation. That you should remember. How to EV-ICD can deliver ATP? Yes, EV-ICD. The reason I didn't bring it up is because it will become complex. We haven't implanted yet enough, but yes, that is an option which is coming up again, which we can consider. So I think I've covered all the questions and it's 10 o'clock.
Wow, thank you very much, ma'am. Thank you for addressing all the questions. This was a wonderful hour. It has been a very great session. On behalf of the entire Biotronic India team, I would like to thank you from the bottom of our heart. Thank you, ma'am, for being very generous in giving us the time, and thank you for the clarity of your thoughts. And on that note, I think we'll draw the session, today's session. And to all the people who have joined, if you have any further questions that you would like to ask Dr. Jaswal, or if you want to know more about Biotronic ICD solutions, you can reach out to us. Our team will help you with that. So thank you very much, everyone. Thank you so much, ma'am, for joining this.
Thank you. Thank you.